Hello everyone, this is Howard Mann. Welcome to the STR webinar. I just want to start the recording again because I've got if it'll work. Seems to be working, I think. All right. David, can you hear me okay?
Yes, I can.
Good. And can you show my screen? Can you see my screen or can you see it now?
Yes.
Good. Okay. All right, let me show the first case. This is not that unusual, but I showed one a couple weeks ago of a mass like this. So this patient presented with, I don't know details about symptoms, but I wouldn't be surprised if maybe findings of venous compression or SVC type syndrome were part of the presentation because that vein is quite narrowed, at least the innominate vein is compressed. But the case is that of this very large mediastinal mass, and there are areas of low attenuation within, certainly consistent with necrosis. The mass certainly appears to be growing to some extent between brachiocephalic vessels, and there is perhaps some upper chest wall soft tissue edema as well. And other structures are displaced posteriorly, of course. And the more I look, there is definitely kind of diffuse body edema as well as pleural fluid as well. And there is also pericardial fluid. So there's actually a lot of pathology, of course. Let's have a look at the PET just to see what is FDG positive. I haven't looked at this case in a while, but certainly as we go up here, we all see there's pericardial fluid. Not surprisingly, there is the mass with substantial FDG uptake within. There appears to be a lesion in the right lung apex, which is FDG avid posteriorly, and there's other ones too. So when I saw a case like this fairly recently, I thought, other than lymphoma, I thought about the possibility of a so-called nut midline carcinoma. And the previous one that I showed was very similar to this one, turned out to be a lymphoma, non-Hodgkin's lymphoma. And it turned out also to be really the same pathology as in this patient, which is a large B-cell lymphoma. So certainly the imaging features are very consistent with that. There's nothing about this that's consistent with a non-Hodgkin lymphoma of the chest. And I presume that maybe the pulmonary findings are related to that as well. But I don't know if that's a separate process, but there are some ill-defined nodules. So just another case, at least another case in my place within a short period of time in a relatively young person of a large B-cell lymphoma presenting as a large anterior mediastinal mass. All right. Let me show you this one. This is a really very unfortunate patient, and I don't have any images prior to this time when the patient is very ill. But let me show you the images and give you the history of breast cancer. You can see that she's intubated, and certainly judged from the amount of tumor that's present here in the right axilla, but the extensive abnormalities in the right lung, that's relatively unusual for metastatic breast cancer, at least in terms of the bulk of disease, is a bit unusual. And the striking finding on this exam in this patient is the presence of tumor invasion of all four pulmonary veins. So let me try and adjust the window width for you. So when we go up here, we can see there's tumor growing into the left superior pulmonary vein. The same thing is happening on the right side, and sure enough, there's tumor growing into the inferior pulmonary veins and then into the left atrium. So all 4 pulmonary veins are involved by tumor. There's obviously pleural fluid as well. I certainly speculated that the opacity, at least in the right upper lobe, was consistent with a consequence of venous ischemia, presumably in the form of hemorrhage perhaps, or hemorrhagic infarction. And this turns out to be a phyllodes tumor, so I'll put up the histology on the right-hand side, but obviously a very aggressive, bad-acting tumor, and really not surprisingly, the patient died soon after this. Previous therapies, I think, had been attempted without success, as you can see there, but unfortunately, a really unfortunate circumstance.
So, phyllodes tumor, breast primary.
Yes, yes.
Got it. Wow.
There was a question as to whether it was a so-called metaplastic adenocarcinoma versus this phyllodes tumor, and they did a whole bunch of immunohistochemistry. She has widespread tumor, as you can see there. But they concluded that it was probably a phyllodes tumor, but clearly a very bad actor. It really is quite awful. And I'm not sure why it chose to grow into the veins like this, all 4 of them. Just very unfortunate.
Dramatic case.
This is an interesting case from the point of view of the MR, well, actually the imaging as well. So I'll take that back. I had 2 cases recently of this entity, but the context of this one that I'm going to show you is a history of, because of ostensibly a nickel allergy, an interatrial septal occluder device that was put in for presumed paradoxical embolism, and a PFO was removed. And that was removed after this in November 2017 by a minimally invasive approach, not a transsternal approach, but a minimally invasive approach. So that device was removed. The patient came back not too long after the surgery with chest pain. And let me bring up a CT that she had in January alongside this. And let me unsync this to show you the pericardial fluid. So certainly the etiology of the chest pain was determined to be a pericarditis. And there is quite a bit of pericardial fluid. And because of the fact that she had had surgery, they thought somehow it was related to the previous surgery for removal of the device. But they treated this patient with a lot of anti-inflammatory medications, I think various ones, as well as high doses, without much relief from her pericarditis, her symptoms. And she eventually came back for repeat imaging, which really showed the same findings, that is pericardial fluid and inflammation. And this is a pretty dramatic degree of hyperintensity on a delayed gadolinium enhancement exam. So very intense inflammation of the pericardial membranes is still present in March. So because of the presence of this and symptoms that were really not relieved, they proceeded to do a total pericardiectomy to remove the pericardium. So a very dramatic case of gadolinium-associated delayed enhancement of pericardium, and pericarditis ascribed in some fashion to the prior operation. I don't know if sometimes the thought is maybe if you have an operation, there are antibodies that may be formed against the pericardium. Can anyone associate that directly with the performance.
Usually it's with open sternotomy that happens, not with a minimally invasive. So I don't know, but what's impressive about the MR is there's also some areas of myocardial involvement along the epicardium. So, most cases you see myopericarditis where you have a primary myocardial pathology causing adjacent pericardial inflammation. This is a less common case of perimyocarditis where you actually get massive pericardial inflammation actually causing adjacent inflammation of the heart.
Okay.
You see that along the epicardial surfaces along the LV is pretty impressive.
I think one of the cool things in this case, Howard, is that along with the pericardial effusion is a predominantly left pleural effusion.
Yeah, there is.
And that's been pretty consistent in my experience. If you have pericardial disease and you're going to have an accompanying pleural effusion, it's going to be worse on the left than the right, unlike the situation with heart failure in which pericardial effusion is worse on the right than the left. So sometimes that's helped me point the clinician toward pericardial disease rather than heart failure as the cause of pleural effusion when it's asymmetric, predominantly left.
Yeah. Yeah, pretty dramatic case. All right, I'll show you another one, which is this one. This credit to one of my residents who saw this last night or early this morning in a trauma patient. So this is a CTA, the usual CTA in a blunt trauma victim. And the finding of interest here is, let me actually bring in the thins. And I'm going to maybe make this one a coronal, as well as make this one, say, a little bit of a MIP as well. So the observation that was made, and I'll mag this up, is this little bump here on the medial aspect of proximal descending aorta. And whether this is clearly a vascular structure, it certainly appears to be that. So I hope you can see this, but I think that the observation is absolutely correct, but I think there is a vessel, or at least one vessel. Let me just try to get to one vessel here, which goes anteriorly. And then if you keep your eye on that, you'll see that that continues, and it's a vessel, and it's giving off a branch that goes in the other direction. So let's look at that in this dimension. And here is the little infundibular-like structure, but it's clearly a vessel. It's giving rise to vessels plural, and one, I think, is probably a bronchial, and the other is presumably a intercostal. So the resident actually found a case report, so I'm going to bring that up now, and I made a PDF of it. So this is from a case of the day from Virginia Commonwealth University Medical Center. And I'll just mag this up a little bit. And they called it a prominent right third intercostal bronchial artery trunk. So here we see that little vascular structure there, proximal descending aorta. And here are some coronal images showing the same thing. And they've ascribed that to this structure called the infundibulum of the right third intercostal artery, or intercostal bronchial trunk. So I think this is what it is. I'm not sure if I've ever seen one before, but it certainly coincides very nicely with their images and their description of it. And it's clearly a vascular structure, not acute aortic injury. Does anyone recognize that? Have you ever seen something quite like that before? Is it just one of these things one might overlook sometimes, knowing it's a vascular structure and on you go?
They're there. They're not that. We see them frequently.
Okay. In that location, particularly proximal descending?
Well, I've never seen it. I mean, I haven't put it specifically at that location, but those little kind of common trunks for multiple arch vessels or descending thoracic aortic vessels are common. And actually, those are the cause a lot of times of those little, when you get dissections or IMHs, those little venous lakes or those little kind of lakes of pooling of contrast are often due to those sitting in the false.
Yeah.
anyways.
One is just got a little diverticulum-like structure, or however you might want to call it, that catches one's eye. But of course, it's small. And I don't think any of us would confuse that with a true aortic mural injury. It's clearly a vessel, as we see there. All right. The last one is just the appearance of the lungs in a person that has a history of chronic granulomatous disease. So, of course, they get infections over time. And I have an image from 14 compared to a more recent one. And certainly there's nothing about this that suggests a particular diagnosis. Obviously, in the time between 2014 and 2018, there's a lot of lung disease. There is scarring in the lungs. I presume what we're actually imaging here is, let me go to the last CT, just opacities in the lungs that are quite extensive, consistent with a manifestation of repeated infections, consolidative opacities. There's airway abnormality. I do wonder to what extent there may be some bronchiolar involvement or bronchiolar narrowing because of relative mosaic attenuation, hypoattenuation in the right upper lobe. So I think there's airway involvement. But otherwise, one really needs the history of chronic infections over many years to account for all these findings. Once you have that history, it's really no mystery. But this is really an unfortunate circumstance. I don't know if the treatment for chronic granulomatous disease is that great, but it's this entity, and it's an issue where your white blood cells don't produce, I think it's some kind of nitrogen peroxide or some other oxidase.
It's acid peroxidase.
That you need to kill bacteria. So is that it? An oxidase enzyme. So this poor individual is really hurting over time. There are mutations associated with that. And I think the relevant here is that you can't make a diagnosis unless you have that information. We can kind of speculate that you might wonder about repeated infections, or without that information knowing what this might be. But once you have an immunodeficiency state, then it makes sense. The one that I typically think of when I see repeated infections is CVID. I think of all the strange ones, that's the most common. But of course, there are other ones, and this just happens to be chronic granulomatous disease. All right, so an example of that entity. All right, who would like to show any cases? Seth, or do you have cases this week? And I'll switch over to you if you do.
Yeah, I do.
Okay.
Let's see here. All right. That should, hopefully you'll see it.
Yep, we do.
I like this case because it's something we don't see a lot about in terms of progression. So this is a patient with pulmonary arterial hypertension and has a lot of the beautiful findings of pulmonary arterial hypertension. These little kind of ill-defined central lobular nodules. But the reason I'm showing this is, more than that. We see a lot of pulmonary hypertension here, which is actually nice. So here you see just a big PA, big right heart. You can tell it's quite an old study. You can almost make out an ejection fraction given the heartbeat here, but you can see the right heart is quite large. That's 2008, and then we go to 2011. And you can see that she's starting to develop areas of subtle calcification along the walls of the pulmonary arteries as her pulmonary hypertension worsens. The parenchymal abnormality with this heterogeneity, mosaic attenuation, these ill-defined nodules, and actually these areas of what appear to be increased ground glass around the pulmonary arterioles, which there's various questionable explanations for that. Increased perfusion, some sort of actual vascular anomaly in terms of the secondary to pulmonary hypertension. Some people say cholesterol granulomas. And then let me, oh wait, the last one didn't upload. Oh, here it is. So, and then we are in 2012. It's just in a different place. And we can see that the calcifications are slightly worse. And then here we are in 2018. And you can see the dramatic progression of these calcifications along the pulmonary arteries. And it's important to note that this is not secondary to chronic thromboembolic disease. These are actually intimal calcifications due to systemic pressures in the pulmonary arteries. The main PA has gotten a lot bigger. You can see that these courses along the walls, just like you would see if someone had bad aortic atherosclerotic disease with severe hypertension, that this is just the progression of, and then you can also see the lung disease over time progressing as well. And the lung disease here is very interesting. It's not really well explained why they get this very heterogeneous appearance. Again, I always like to say it's kind of as the little central lobular nodules, presumably due to blushes around the pulmonary arterioles within the center of the secondary lobule. And you get areas of parenchymal destruction for, who knows, maybe due to infarcts, not really sure why, but just a very dramatic case of progression of intimal atherosclerosis in the pulmonary arteries in a young patient with severe pulmonary hypertension over 10 years.
And this is idiopathic pulmonary hypertension?
Yeah, it's pulmonary arterial hypertension. No meth use, no, it doesn't look like classic PCH or PVOD, which we see actually a fair amount here. But nonetheless, she doesn't have heart-lung transplant, which she's waiting for to confirm that there's, even those are still pulmonary arterial hypertension. Yeah, she has no collagen vascular disease, no underlying, even that's pulmonary arterial hypertension technically. No secondary cause. And this is an unfortunate young woman who, I know Howard showed a case of this, I think a couple months ago. Young woman with coming in with chest pain, has this area where you can see the right upper lobe pulmonary artery branch here is pretty much gone, and there's an associated infarct here, but there's this large mediastinal mass, it's just confluent soft tissue in the center going kind of with a right hilar node. And she underwent biopsy of this and it came back squamous cell, and she was like 29 years old. And they were concerned about a nut midline tumor, and they did all the genetics and stuff, and this did come back as a nut midline carcinoma, that it was positive for the antibody or that they used to test for that. And it's a very aggressive tumor. She lived for about actually a year. She just passed away recently. It's, the average, I think, survival for these is about 6 months. And so they were not pleased that she passed away, but she got a few more months than is typical with nut midline carcinoma. People here they're very rare, as we know. We've seen 2 here, but this patient had a pretty classic case of that. And then the last case, let's see what month this is here. So this is a patient who is a drug user, uses his intravenous drugs. He already has his first prosthetic aortic valve, and you can see that a few months after surgery, he has this fluid collection surrounding his aortic root, and then you can see this very small outpouching from the aortic root here at the level of the anastomosis, right, kind of inferior to the annulus or at the level of the annulus. So he's got a little pseudoaneurysm. Now, they sat on it. You can see here when you look down the plane, they sat on this because of the infected space here, and they treated him with antibiotics, and he kind of disappeared for follow-up, and he came back. This is about 2 months later, and you can see that in 2 months, without his appropriate treatment, you can see that this has turned into a complete mess where there's just massive pseudoaneurysm involving the root here. So you can see that there is now, instead of just a small little pseudoaneurysm that was down here by the annulus, there's this massive, just huge pseudoaneurysm involving both of the leaflets. And the other interest, not leaflets, but just involving the aorta. And then the other interesting thing is that you can kind of see here that this big guy is, maybe it's better. We have a cardiac study the next day. You can see it better. But this big thing is actually compressing the left main coronary artery. And here you can kind of see it. So here is the left main, and it's being squished and stretched as it goes over this huge pseudoaneurysm. And you can kind of notice here that there's some hypoperfusion of the left main territory in relation to the inferior wall. So here you can see. So anyways, they took him to surgery. He did fine. His heart perked right back up. Didn't have any long-standing sequela of that left main squeezing and compression and stretching. And now he's discharged, and I'm sure he's going to go back to using his heroin. But nonetheless, a nice progression of a pseudoaneurysm. So those are my cases.
Wow.
That's pretty scary looking.
Yeah.
Very.
No, I called the surgeon. He's like, yeah, he's fine. He's pretty. Most cardiac surgeons pretty low key. He's like, yeah, he's fine. Don't worry about it. We'll take him to surgery sometime. And then he's fine.
So what surgery did they do? Did they repeat the AVR, or did they leave the?
Oh yeah, no, they took everything out. They literally just cut down below the AVR and just put in a whole new aorta from basically composite graft with a valve, new root, and new ascending aorta. But yeah, just I thought it was nice to see the left main being kind of pulled and squished. I thought that was interesting. That's all I got, Howard.
Okay, thank you. So I think that I've shown you my cases. So has Seth. I think some folks are away at meetings this week. So it seems like we'll have a half-hour meeting this time. And we'll be back with more cases next time. So David.
Right, sounds good.
Thanks, everyone. Thank you.
All right. Thanks. Good conference. Good half hour.
Take care.
Take care, everyone. See you next time.
Bye-bye.
Bye-bye.